So the interrogator, myself and Dr. Rahul sir, who needs no introduction. And before we begin, the only thing more complex than facial anatomy is choosing the correct answer in an MCQ. But here we are going to have MCQs on facial anatomy. So just please give your attention here. And short answer questions, because you don't need a dissertation for very small answers and small topics, because sometimes less is more unless you are removing a tumor. So now to start with, this has already been covered. Which of the following is the most superficial structure encountered during a cricothyrotomy? So anyone? Cricothyroid membrane, yes. So that's the first structure after you put an incision. So the answer is cricothyroid membrane. So what is the clinical significance of the cricothyroid membrane? Anyone? Very easy, it has already been covered. So it's a site for emergency cricothyrotomy, right? So the membrane is easily accessible in life-threatening airway obstruction. So this is the cricothyrotomy. As soon as you put the incision, the cricothyroid membrane is very much approachable, and then you can establish airway through that in emergency situations. Now, can anyone tell me the absolute indication for surgical airways? Not necessary altogether, one by one. Very simple, very easy.
You have half an hour still. After that, you can go home and sleep. Acha? Abhi, please answer the questions.
Because you cannot sleep when you have airway obstruction, right? So wake up, guys.
Yes?
Come on.
Raise your hand. Absolute indications.
I can see some 15 chocolates here.
Obstructive sleep.
See, we are talking about absolute indications. Absolute indications. Okay? Yeah.
What about the point of GCS? Talk about see about the when a trauma patient is coming, you can't just say trauma. You have to see the neurological part also. Say about that. GCS below, how much you will do a tracheostomy? Right? What else? Retro?
No
So,
chocolate.
see the patient has got a maximum.
No chocolate.
No?
Yes, so severe upper airway obstruction, laryngeal fracture, maxillofacial fracture, severe burns, foreign body obstruction, severe laryngeal edema caused by anaphylaxis, burns, infection, cervical spine fractures, failed intubation attempt, inability to intubate after multiple attempts, inability to maintain oxygenation and ventilation, severe anaphylaxis, congenital or acquired upper airway obstruction like laryngeal anomalies, cancer, severe tracheal stenosis, and massive hemorrhage with airway compromises seen in neck trauma, ruptured aneurysm, vascular injury, or tumor rupture. Now again, very carefully, which of the following is not an absolute indication for emergency surgical airway? So just now I have narrated all the indication. Now which one is not an absolute indication?
Raise your hands. Raise your hands, please. Who wants to answer? Please raise your hand. Okay. B. Failed intubation in patient with severe facial
No,
trauma.
that is one of C. Yes, exactly. So in airway for prolonged ventilation, patient is already intubated. You already have airway. You just need to shift them to a more permanent airway. So that is not acute emergency. Now, which of the following is the preferred method for an emergency surgical airway in an adult?
Again, raise of hands.
Needle.
वो पीछे उन्होंने सबसे पहले रेज किया.
Adult emergency surgical airway. It's surgical cricothyrotomy for adult patients.
It is not the
It
needle.
is-
Why the needle is not? Because when you put the needle, the amount of air you have to give it around 15 liters per minute, and the inspiration ratio should be 1:4. So you can only pump 250 ml of oxygen. That also will not be going to the trachea. You cannot ventilate these patients, so there is large accumulation of carbon dioxide. So you have to do a surgical picothyroidectomy, not a needle. Needle you can only put and you can prepare for the patient for surgical picothyroidectomy. That's it. Right? Needle is for children it is. You can go and do a tracheostomy. There is no picothyroidectomy for children.
So the next question is for the pediatric patients. So in a pediatric patient requiring an emergency surgical airway, which of the following is the preferred method? Exactly. So for children under 12 due to risk of subglottic stenosis, you don't go for surgical cricothyrotomy. So the needle cricothyrotomy is the choice of airway method. So in head and neck cancer patients, a surgical cricothyrotomy is contraindicated if the tumor involves the cricoid cartilage. True or false? Just guess, true or false, quickly.
Simple.
True. So tumor involvement of the cricoid cartilage makes cricothyrotomy unsafe due to risk of tumor disruption and the bleeding. Now anatomical landmark for tracheostomy, A, B, C, D, quickly. You can just answer anyone.
B. A is the Adam's
A is the thyroid notch, yes. Then B is yes.
and then C is the trachea.
Yes, trachea.
And 4 is the
Suprasternal notch. Excellent. So these are the marking for tracheostomy. Now the ideal position for tracheostomy is okay B. So why not A and why not C? So a low tracheostomy may compress and erode the innominate artery, which is a grave complication which you would not like to see as a surgeon, resulting in a fatal hemorrhage. And a high tracheostomy above the second tracheal ring can cause subglottic edema, chondritis, and subglottic stenosis. So, in general situation, just go for second and third tracheal ring.
But in patient with stridor, possibly laryngeal cancer.
Agreed. So this is a normal situation we are talking about. There are exceptions where you would do a low tracheostomy like tracheal injury or any tumor in the trachea or laryngeal malignancy.
So in case of, I just want to add one point here. In case of too low tracheostomy, you can encounter the apical pleura as well. Apical pleura, too low tracheostomy. That is why 2 finger breadth above the sternal notch. So if you go too deep, too apical, the patient can get a pneumothorax.
Yes.
Then you have to get
children and also in patients having COPD.
right. I just wanted to add this.
Yeah. So the next question about tracheostomy care, which of the following is not a routine part?
C.
Yes. So daily tube changes is not required. If you are doing proper suctioning, humidification, and stoma care, I think that is something which is not required daily. But other 3 are very important on regular basis. So which of the following is the most common early complication of tracheostomy?
Early complication.
Early complication.
Raise your hands.
Yes, bleeding. So bleeding is the most common. So jugular vein or thyroid edema, any of these vessels are there. So you just need to be careful. Now name any late complications of tracheostomy. Then fistula. Which fistula? What fistula? Sorry? Which fistula? Tracheoesophageal. So first is tracheal stenosis, second is tracheomalacia, and third is tracheoinnominate fistula. Right? So tracheomalacia is something where the structure of the larynx is injured, and ultimately during the expiration the entire tracheal wall collapses. So that is one of the important complication, and another is tracheoinnominate fistula. So now coming to tracheoinnominate fistula, can it be managed conservatively with antibiotics? True, false? False. Why? So now you need to understand that the innominate artery, it is between the sternum and the trachea. When you do a low tracheostomy, because of the pressure of the cuff, there is a friction, and ultimately the artery might just rupture. So it's an emergency. Patient will bleed like anything. If you inflate balloon, because of the tamponade effect, the bleeding will stop. But you need to take the patient to ER, locate the bleeding, call for a vascular surgeon. You probably need to put a patch where there is erosion and in the arterial wall, and you need to address it immediately. Otherwise, you might just lose the patient. which now is at risk of surgical, during the tracheostomy. Exactly. So it is in the right and left tracheoesophageal groove. So don't just go too laterally, just stay in the midline. A patient develops subcutaneous emphysema and respiratory distress immediately after a tracheostomy. What is the most likely cause?
Pneumothorax. Tube placement.
So tube displacement into pretracheal region will cause just the emphysema. Now patient here, there is a respiratory distress. So the answer is pneumothorax because of the injury to the posterior tracheal wall. So just to summarize, tracheostomy, cricothyrotomy, the definition, it's a tracheostomy, it's opening in the trachea, cricothyrotomy in the cricothyroid membrane. When you need a long-term airway, go for tracheostomy. In emergency situation, cricothyrotomy. The early complications are more or less same. The later complication we have already discussed. In children, tracheostomy can be performed. You need special equipment, skills. Cricothyrotomy is preferred when the age is more than 8 and below 12. Don't go for surgical cricothyrotomy. Go for needle cricothyrotomy. So now, before getting into this, I think, so let's just discuss the scenarios.
Maybe just a couple of cases, then we'll stop.
Okay, sure. So the first scenario, 52-year-old male with Ludwig's angina, trismus and impeding airway obstruction. So there is airway obstruction, he is unable to open his mouth more than 1 centimeter. What is the most appropriate surgical airway for this patient? Anyone? Tracheostomy, yes. So since this patient has impeding airway obstruction, you should go for tracheostomy. Ludwig's angina, trismus and swelling makes oral and nasal intubation difficult. Now another patient, 25-year-old, brought to ER with high-speed motor vehicle accident, several facial trauma, mid-face instability, nasal fracture, blood in the oropharynx, is unable to maintain his airway. Choice of airway. Come on, already discussed. B, surgical cricothyrotomy. So in severe maxillofacial trauma, oral nasal intubation may be impossible. Due to fracture, surgical cricothyrotomy is the fastest. The tracheostomy is preferred over cricothyrotomy if the patient is stable and the procedure can be performed electively. And last, a 50-year-old male patient with a history of squamous cell carcinoma of larynx, previously radiated with reports with stridor, difficulty breathing. Image shows a recurrent tumor compressing the trachea. So what is the most appropriate surgical airway?
Surgical.
Come on, someone? Yes, so that's tracheostomy. Patient with recurrent head and neck cancer and prior radiation, the tracheostomy is preferred to avoid tumor manipulation and radiation fibrosis. Thank you.